Good evening, everyone. My name is Julia Joseph, and I welcome you all to the launch of Whitepaper on Catalyzing and Reforming Senior Care in India. We are honored to have the august presence of Dr. Vinod Paul, Honorable Member Health from Niti Aayog, and Csr Subramaniam, Secretary, Ministry of Social Justice and Empowerment, for this launch today, along with our forum leaders and members. In order to create the much needed awareness among the stakeholders, including the government bodies, the Senior Care Forum, under the aegis of Nat Health India, in collaboration with Association of Senior Living India, ASLI, FICCI, and Medical Technology Association of India, in technical collaboration with PwC, has put together this white paper. India is going through a demographic shift. From being a young nation, India is seeing a sharp rise in its elderly population since past few years. It is estimated that by 2030, 12% of India's population will be over the age of 60. Growing elderly population was a potential threat to the already stretched healthcare ecosystem. The elderly care demands adequate attention of the government, philanthropists, and the sector players working in the space. And we hope this white paper will serve as the catalyst for the much required change and attention in this space. Before we start, I would like to make housekeeping announcements. For our audience, please use the Q&A function below your screen to type in your questions. The moderators will be able to see and address them. Please mention whom your question is addressed to. For the opening remarks, I would now like to invite on screen a few of the Senior Care Forum representatives. First, we have with us Mr. Ankur Gupta, Chairman, Association of Senior Living India, and Joint Managing Director, Ashiana Housing. Welcome, Mr. Gupta, for the opening remarks.
Thank you, Julia. Thank you. And thank you, everyone. It's a pleasure to be here. I'd like to welcome all the distinguished guests and colleagues who are here. It's just a pleasure to be in a forum where we are talking about catalyzing and reforming senior care sector in India. As we're all aware, and as Julia mentioned, that we are an aging population now. We will have the speed of aging will grow over time, and by 2050, the population is at 20% of Indian population will be in the aging need. I think as the aging population has gone up, and with COVID-19, we have realized the vulnerability of this segment. And it's great to see a lot of us as the senior care sector had come help during this period of time, but it also tells us that we need to figure out for the future what reforms, what things we need to do so that we take care of it. At the same time, when we talk about seniors, we only think about medical and we don't think about other areas. And I think it's very important to figure out what are the other areas. And if you look at data, it says that more seniors die because of loneliness and of falls than of medical reasons. So that means that we need to keep an eye on various aspects of the infrastructure, the service needs seniors have, the active lifestyle they need to live to get a better understanding. We're in a decade where actually United Nations has announced this decade as decade of healthy aging. And that just tells us the importance, not just at an Indian level, but at a global level we have for taking care of the seniors and making sure we do the right thing. As in India, this grows. What is interesting to see is that Ministry of Social Justice last year had come up with a lot of interesting policies or things to do, which can help seniors age better, from raising CSR funds to coming up with Sacreds, which is a job portal for seniors, as well as investing in tech companies which look at senior care. So there's a lot of initiative, but I'm also glad with this white paper which has come out, the amount of research which has happened. I think it'll give us new directions and new reforms which can really look at the senior care sector differently. As the businesses grow, it will also help the seniors who are aging in the country at a different level. So I'm very excited about the same. I think the way the paper has taken a look at the emotional and cognitive need, the mobility and disability, financial housing needs, awareness and knowledge, and just not medical. So the whole idea is it's a 360-degree approach to the paper, and that makes it far more interesting. And I'm always excited about the housing side myself, and that also is covered in the paper very well. So looking at this, I'm very excited about what the panelists are going to talk about. I'll be listening eagerly. And thank you so much for making me a part of this event, and very excited to be in the senior care sector, where we can actually make a difference in people's lives. So very excited about the same. Thank you so much.
Thank you, Mr. Gupta. I would now like to invite Honorary Brigadier Dr. Arvind Lal, Chair, FICCI Swasth Bharat Task Force, Executive Chairman, Dr. Lalpath Labs Limited, and Managing Trustee, ALVL Foundation, for the opening remarks.
Thank you very much. Good afternoon, distinguished speakers, industry colleagues, healthcare experts, ladies and gentlemen. I would first like to extend a very warm welcome and especially thank Dr. Vinod Paul, Honorable Member Health, Niti Aayog, Mr. R. Subramaniam, Secretary, Ministry of Social Justice and Empowerment, leaders of the associations that have come together in a unique manner for the cause of senior care, led by Mr. Ankur Gupta, Chairman ASLI, Mr. Pawan Chaudhary, Chairman and DG MTI, Dr. Harsh Mahajan, President Nat Health, Mr. Siddharth Bhattacharya, Secretary General Nat Health, and especially the senior care forum leaders like Mr. Rajat Mehta and Ms. Nanki Singh. And last but not the least, the Price Waterhouse Cooper team led by Dr. Rana Mehta himself. Thanks for joining us in this important endeavor and this roundtable, which is a curtain raiser for a series of reforms in senior care in India. This is a very opportune time to bring senior care in focus, considering the changing demographics in India. As you've just heard from Ankur, that by the year 2050 or 2050, 20% of our population, that is nearly 33 crore people, will be above the age of 60. Aging is a highly individualized journey and its challenges, medical as well as non-medical, and cannot be addressed by a one-size-fits-all approach. Therefore, it necessitates an integrated intervention to address the diverse needs of this segment of the population. A recent WHO report on aging and health emphasizes that aging or healthy aging is more than just the absence of disease. A holistic definition of senior care goes beyond just medical care and includes financial security, social well-being, and dignified living. The elderly of today wish to live active and productive lives with independence and to add years of good health to their increased longevity. The elderly of the future will also have similar goals and priorities, but along with better affordability, as well as willingness to invest in their golden years. They will also have a higher affinity to using health technology and wearables to maintain an active and healthy lifestyle. As a country, we need to take concrete steps to support our aging population that would include, firstly, building a senior-friendly society. Number two, transformation of health systems with dedicated infrastructure and services for elderly, including geriatric departments and wards in medical colleges and district hospitals, along with cadres of healthcare workers specializing in geriatric care. Thirdly, the provision of financial assistance. Next is adoption of maintaining of simple, cost-effective innovations. And finally, a well-financed national program under which the above-mentioned interventions can be implemented. You all would agree that while India's economic position and healthcare ecosystem have significantly improved over the years, our elderly population still remains highly vulnerable to severe health challenges, including both communicable and non-communicable diseases. In addition, they face numerous challenges ranging from economic security, accessibility to public services, along with abuse and neglect from family and society. We must create a robust and inclusive senior welfare ecosystem. It is high time that we introduced a dedicated national mission for aging and senior welfare with active participation of the central and state governments, industry, and the civil society. With this view, FICCI's Swasth Bharat Task Force, which works on key priority areas in Public Health has partnered with ASLI, MTI, and Nat Health to develop a white paper on catalyzing and reforming senior care in India with PricewaterhouseCoopers. I would also like to thank my colleagues and experts from the FICCI Swasth Bharat Task Force, firstly Dr. Arun Agarwal, Dr. Sunila Garg, Mr. Ashok Kakkar, and Dr. Vikas Malhotra, who have dedicatedly contributed to this paper with their valuable insights and suggestions. Thank you very much.
Thank you so much, Dr. Lal. We have with us Mr. Pawan Chaudhary, Chairman and Director General, Medical Technology Association of India, MTAG. Welcome, Mr. Chaudhary, for the opening remarks.
Thank you, and it's a pleasure to be with you all. I would like to bucket my remarks under financial, physical, and socio-psychological. First, the financial. I'm reminded that Khalil Gibran said that when the father gives to the son, both are happy. And when the son gives to the father, both are unhappy. He was speaking in terms of money or financial assistance. This is a very important problem today, which the elderly are facing because of rising lifespans, a sandwich generation of their kids who are also old enough and who also have to care for their children. The susceptibility to fraud, financial fraud, which is often wreaked upon these elderly by their near and dear ones, by insufficient savings and lowering interest rates, by difficulty in finding alternate employment, and increasing healthcare costs. Millions of people, because of this in India, are heading towards elderly poverty. In the socio-psychological side, any society, how it treats its elders, depends on the usefulness of elders and its value system. Because of the technological changes which we have seen, the availability of knowledge, the other social dynamics of family which have changed, emergence of nuclear families, mobility, the value of elders as a resource has gone down. As far as value system is concerned, we have a very strong value system of respect and caring for the elder, but it is more in print and scripture than in practice today. So today, because of rising social indifference, the elder is becoming lonely, depressed, and alienated. There might be some leftover feelings of resentment also in the family, or anger or unresolved issues which further complicate these things. The last is the physical and the mental piece. Aside from a deteriorating body, the elder has to often follow an atypical disease course, multiple pathology, and he needs polytherapy. The elder caregiver also doesn't have many a time the right training, motivation, doesn't have referral access, and is often prone to burnout. The infrastructural requirements, which my friend Ankur spoke of, also the country is not very tuned to how an elder, for example, requires grab bars in the bathroom, a bench to bathe, wider corridors, etc., or railings is not incorporated yet in allied industries like real estate. And what I like about this report is, for the first time in the country, it fully illuminates the plight of the elder. So it is not only a strident wake-up call, it is also a blueprint for elder care reform. And with the presence of Dr. Paul and so many distinguished leaders today, I feel that this will not be just a report which will be filed, but it will be a program of action so that this severely disadvantaged community gets the due it deserves. Thank you very much.
Thank you so much, Mr. Chaudhary. I would now like to invite Dr. Harsh Mahajan, President, Nat Health Healthcare Federation of India, and founder and chief radiologist, Mahajan Imaging, for the opening remarks. Dr. Mahajan, you are on mute.
Yeah, thank you very much, Julia. Professor Vinod Paul, Honorable Member Health, Niti Aayog, an eminent pediatrician, policymaker, someone who has led the fight against COVID for the last 2 years, and who always is available for the healthcare industry. Thank you very much, sir, for sparing time during these busy days to join this program. Mr. R. Subramaniam, Secretary, Ministry of Social Justice and Empowerment, Mr. Ankur Gupta, Honorary Brigadier Dr. Arvind Lal, Mr. Pawan Chaudhary, Mr. Rajat Mehta, Ms. Nanki Lakhvinder Singh, ladies and gentlemen, and my colleagues from FICCI and Nat Health, who've actually worked very hard to put this paper together. Nat Health, FICCI, ASLI, and MTI have convened a cross-sectoral task force of senior welfare specialists and key industry stakeholders across providers, insurers, senior living players, as well as academicians from across the country in this endeavor. The forum over the last year has created a white paper on catalyzing and reforming senior care in India. This is a sincere attempt to put forward perspectives from all industry stakeholders and propose recommendations with welfare of the Indian senior at the epicenter and at the heart of this document. The paper is a product of collaborative effort of the industry with expert inputs, especially from Niti Aayog, under the guidance of Dr. Paul, Ministry of Health and Family Welfare, Ministry of Social Justice and Empowerment, NPH, CE, NHS, RC, the LASI study, IGNOU, and multiple key government stakeholders working in the area of elderly care. The paper identifies 6 key functional modes that could act as the pivot to bring about an accelerated transformation of India's elderly care landscape and enrich the silver years of the Indian senior. The set of recommendations encompass creation of a financing of care for seniors which is aimed to sustainably fund all aspects of care. Some of the key recommendations include mandatory or tax incentivized contributory health savings scheme to encourage savings by all citizens in the high income category during their early years to fund senior care needs and manage out-of-pocket expenditure in the silver years. Affordable private insurance to cover all aspects of medical and non-medical care, including home-based and outpatient services, while optimizing insurance premiums and reducing out-of-pocket expenditure to increase access and affordability to care. Expanding coverage to seniors of low and middle income category under the PMJ scheme, which is coming into its own since the last 3 years that it has been around. And efficiency measures to prevent ballooning of cost of care with an increasing elderly population. We are honored today, sir, to be releasing this pivotal body of work in presence of key policy makers who are the custodians of health and well-being of this critical demographic segment. Demographic shift is a defining trend of our times, as we've heard all the previous speakers say. Over the course of today's deliberations, I hope that we find common next steps while unlocking the levers that usher in health, prosperity, and happiness for the silver economy. I welcome you all again, and may we have a very, very fruitful discussion today. And thanking you again, Dr. Paul, for finding the time to grace this occasion and release the white paper. Thank you.
Thank you so much, Dr. Mahajan. We have with us Mr. Rajat Mehta, Senior Care Forum Leader of Nat Health and MD and CEO of Antara Senior Living Limited, along with Ms. Nanki Lakhvinder Singh, Senior Care Forum Leader for Nat Health and Managing Director of Pro Tribe Senior Care Services Private Limited, who will be presenting the report and also share the industry forward.
Thank you, Julia. A very warm welcome from my side, Dr. Paul as well. Dr. Paul, I'm hoping and praying that we'll be able to utilize a part of your energy and dynamism to give headwinds to this sector as you have done in healthcare. A special thanks to Mr. Subramaniam as well, who has led this in the forefront for the last 2 years, trying to put a blueprint for developing the sector. A big thanks to Dr. Mahajan and Dr. Lal, Pawan, Nanki, Rana, Ankur, Siddharth, for helping us put this white paper together. Indeed, it's a very, very important milestone where all federations have come together. And Mr. Subramaniam says it's a national problem needing a national solution. And hopefully this paper will provide some light towards that. I'm going to start with sharing an anecdote which perhaps highlights the state of seniors in India. So we have, our neighbors, Mr. and Mrs. Kapoor, mid-80s, living in a house, son in US, daughter in Singapore, with a house help and a driver. And when the first lockdown came, the driver couldn't come back because he was on leave in his hometown. And the house help was down with COVID. And that's when everything went topsy-turvy. They struggled for essentials. They struggled for housekeeping. They started ordering food from outside. Cash at home ran out, and they're not the ones who know how to use Paytms or credit cards online. Of course, all of us pitched in. And remember, these are quite affluent people with lots of resources and means at their disposal, not typically representative of the average senior in India, and yet they struggled. So you can see from this one example, right, what could be the possible state of seniors across India. And while this report goes into lots of details on age and disease burden, there was a very interesting survey that we did about a year back of 3,000 seniors in Bangalore, Mumbai, and Delhi. And we found to our surprise that 77% of them were staying alone. I was taken aback by that figure, which means the traditional system of joint family or community care also has broken down. And when we asked the seniors, what are the main challenges they face? The one insight we discovered, and they said it in their own words, which said that the basic issue was one of connectedness. And Pawan, talked about, social isolation. And the words they used, they said, we stay in the same house with our children. Baatein hoti hain, par baat nahi hoti. They say even to meet their son or their daughter, they have to look for an opportunity, which really is quite, telling on how seniors are feeling today in India. And I think it's very, very important, very, very opportune that we have taken the step to study the problem, to look at the various aspects of the challenge, and come out with some recommendations which perhaps can provide an action plan for the next 2 decades or so. So, everybody talks about the elderly population in India. We know that it's an aging, demographic. Life expectancy has gone up. 40% of our seniors suffer from cardiac conditions. 17% suffer from dementia, which we know is a grossly underreported figure in India. And insurance penetration is quite low. It's quite surprising. The other unfortunate, not so comfortable fact which I discovered as part of my healthcare journey, that people are very willing to spend on their children. When it comes to spending on their parents, suddenly the purse strings start getting pulled back, which is quite unfortunate. So this, study has gone into great detail of looking at the National Program for Healthcare, the LASI report, the National Action Plan for Seniors, and therefore the recommendations are quite specific and quite detailed. This slide perhaps talks about, and lays out all the recommendations. There are the foundational components, which talk about having an integrated governance. Today, we're not very sure which ministry covers which aspect of senior living. Care at home is separate, assisted living is separate, senior living facilities are separate, insurance is separate. So First recommendation that the paper is making is saying, can we have an integrated governance, perhaps a national aging mission, which can look at all aspects of the senior care sector. Second, most important is financing. 90% of the expenses seniors make on health or health related are actually out of pocket. There is no insurance cover beyond a certain age. There is no insurance cover for care at home. There is no insurance cover for assisted living. There is no reverse mortgage product in the country today. Therefore, financing of care is a very, very important foundational component. And the third one, obviously, is a proper regulatory framework, policy, structures, quality certification, standards, which can then help develop the sector properly. And then we have, 3 enablers for growth. Most importantly, capacity building. This is something that the healthcare sector has faced and also solved to some extent. Today, if you look around, very few geriatric care specialists are available, whether it's clinicians, nursing, or caregivers. Very few have specialization in geriatric care. So how do we create that workforce? How do we train that workforce? How do we make ourselves digitally ready to improve access and efficiency, for the elders? Looking at the private-public partnership as a synergy area, if you look at trends across the world, and we have studied trends in Japan, in US, Denmark, UK, there is more and more active participation by the private sector along with the government. Tax reform, just to give you an example, today, if the hospital imports a medical equipment, it pays only 5% GST. And if the same equipment is imported by the senior, he or she has to pay 18%. So anomalies such as this need to be just ironed out. There's plenty of CSR money available in the country. So how can some of that be funneled through to develop the sector? Fostering innovations. We have learned through our wonderful journey in the last 6 or 7 years in healthcare, how important technology and digital is. So if we can look at, remote monitoring systems, how to make home environments more safe through technology using AI and ML, that would be, fantastic. And then there is a 3-tiered approach of how do you create, more and more employment opportunities for seniors so they're financially independent. What kind of social safety net is required, what support systems are required. So the entire paper looks at 12 areas or 12 specific recommendations, which can then help promote active, healthy, and productive seniors, better health outcome with an improved quality of life, financial protection, and therefore a thriving silver economy. We've also taken the liberty of putting this in terms of scale of impact and time to impact. All the 12 recommendations. So if you look at, on the left-hand side, we can look at the Atal Innovation System, missions, system for looking at, innovations in this space. Private insurance is a very important, recommendation the paper makes. And this is something that, I hope we can dialogue through Dr. Paul or through the Ministry of Finance or Ministry of Social Justice with the IRDA. Like the COVID product, which came out very quickly, perhaps, a product which covers seniors for assisted living and for care at home could be considered. There's already work going on through the Ministry of Social Justice on how to look at the CSR, funds to be used for senior care, GST exemptions, a mandatory contributory savings scheme, perhaps, for seniors, digital technology, manpower capacity. So I will not read out through the entire list, but these, recommendations are well researched. And I will now request my colleague, Nanki, to take you through the specific recommendations and details. Nanki, over to you, please.
Thank you, Rajit. Julia, could you pull up the other slide, please, as we go through this?
Sure, Nanki.
Perfect. So I'm going to present Rajit's point of view from a different perspective. This is from the perspective of how all stakeholders have are in the stakeholder actually. Oh, sorry, pardon me. The sector holds interest for all stakeholders. The ecosystem in India is developing. It's in its infancy, and that's clearly why we are here. Representing an industry point of view on how this ecosystem could actually develop and what can augment it, I believe that the sector can be divided into 2 key components. One is the real estate sector and the other is the care part of it. The sector has ability to fulfill all sorts of ambitions: philanthropic, for-profit, yield immediate return on capital, long-term patient capital returns. Every stakeholder can find their spot, choose to play, stick to it, and just be agile and innovative in their approach as they move through developing this sector, whether for business or for philanthropy, for not for profit businesses, or for government perspective. Like I mentioned, that the two key pillars to this entire segment. One is real estate, which is senior housing. A lot of real estate players are coming in today on what is fast becoming community living. Perhaps the reason why community living is becoming fast growing is because loneliness is becoming a factor, and we've all highlighted that in the past conversations. The target population is baby boomers who are very capable of living on their own and want to continue to live on their own. They do not want to live with their kids, be a burden on them, or they feel that they're taking from their kids. So this is a high and mid segment part of the population who are opting for senior living communities. But then parallelly, low income housing as a philanthropic activity can also be developed by the government to significantly help an aging society. Care, on the other hand, care is where the long-term play lies. Elderly need empathy and care, the need of which only grows as one gets older. A well-structured environment can contribute immensely to quality of life and decreased burden of health on acute healthcare systems. We are already burdened with less doctors, more patients, lesser number of beds, more population. The way we can decrease this burden further is focus on rehabilitation and subacute care. It's important to have differentiated expertise of care in various settings, whether that's at home or that's in institutionalized care. Expertise can include memory care, long-term care, assisted care, and something as basic as social engagement. Adult day care for social and active, meaningful engagement is another service from a care perspective. The expertise supplemented with rehabilitation, which is occupational therapy, speech therapy, and physical therapy, especially post-surgical and post-event, can contribute significantly to a senior's life and quality of life therein. I would want to put forward that rehabilitation is often misinterpreted in society. It is not given the importance that it should be given. As correct rehabilitation post-event can really improve quality of life of people. Institutionalized care is an opportunity to explore via the real estate route. Small to medium-sized centers with a strategic fill plan to sustain occupancy can be built out for long-term and short-term play for seniors. This requires patient capital and long-term returns from an industry perspective. While these components of real estate and care may be core, but the ecosystem is not complete unless facilitated by the recommendations of this white paper. These are the true enablers of this ecosystem. These can be only be implemented by well thought out government guidelines, a mission like a mindset and licensing that will create paying capacity among seniors. It'll further enable quality control and framework of services to be provided. A well-trained workforce and geriatrics as a professional, as a preferred profession are key to delivering quality care. Technology and consumer equipment must be tailored to provide solutions for seniors. At the delivery end of the funnel, all these enablers must be used to create awareness amongst the services and the options that are available to the seniors as a special segment of society. Our consumers, which are seniors, must know that they are not alone and can seek help to live a fulfilling life in their senior years, and that they are the torch bearers of society and civilization. They are valued, they are relevant, and they hold and they are owing to their experience and their age, they can bring a lot to society even in their silver years. To conclude, I would like to say that it's only with the support of the government and industry bodies alike that this white paper can have legs to propel the cause of seniors forward. A very special thank you to Dr. Paul, who has laid out the core areas of focus with That Health in this regard. Also, a note of appreciation for Mr. Subramaniam, who has enabled 7 task forces on this subject. Perhaps we can request him to have wider coverage on these task forces, combining the efforts of various ministries. We are also working closely with Dr. Subramaniam to establish a Skilling Council of India dedicated to the workforce for seniors. Thank you once again to Dr. Paul, Mr. Subramaniam, Dr. Lal, Dr. Mahajan, Dr. Rana, and Vijay especially, and the entire PwC team. Without the efforts of Pavan, Siddharth, Rajit, and Ankur, and the entire Nat Health team, this wouldn't have been possible. They have all been keen putting this together. My submission would be that we have to keep the momentum going so that we can benefit as a society. Thank you.
Thank you so much, Mr. Mehta, as Ms. Singh, for taking us through the report and sharing the industry perspective. As a special guest, we have with us Csr Subramaniam, Secretary, Ministry of Social Justice and Empowerment. I would now request to please address our attendees.
Friends, it is my privilege to speak to all of you on the occasion when Asli, FICCI, Yamtal and Nat Health have come together to organize this virtual roundtable to look at the senior care system and also look at ways to catalyzing and reforming the sector. This is a very important topic for discussion because all of us are grappling with the problem of a better care for the seniors in the society. And I think all of us understand very clearly that we are still a very long way off before coming to a satisfactory situation. So friends, I would be looking forward to read this white paper which you are bringing out. Normally white papers are brought out by government, but in this sector we believe that there is no difference between public and private. We must work together, and then only we can bring in a national solution. It cannot be a government solution, it has to be a national solution addressing the problems of the elderly. So friends, I would be looking forward for this white paper and to be led by it, by the conclusions, to see where we can plug in from the side of the government, support you, and so that we can create a better ecosystem for the elder care. I just wanted to flag 5 issues today, and I'm sure as the discussions progress, you will focus on them apart from the other pressing points that each of you would be having. First of all, we are looking for developing standards for each type of the institution in the senior care ecosystem. There could be old age homes, there could be assisted living communities, then there could be healthcare units. Every single type of an institution that is there in the elderly care segment would need to develop standards and bring in some sort of a self-regulation so that the institutions which are in this particular segment function in accordance with these standards. This will also set a clear target for each of the institution which is in this segment as to where they would have to reach in order to come to a satisfactory situation. So developing the standards is something which we are currently engaged in, and we have a lot of support from all of you, from many of you, and so we would be really looking to build on that. Right now we are not going to give immediately a legal sanction to it, but I was trying to see whether these standards which are developed, industry standards which are developed, are actually adopted by all of you, all the stakeholders, on a voluntary basis. I think that is something which will be a very good first step towards building up better institutions. Second thing, friends, we are really seriously looking at the health insurance cover for the elderly. I think that is something which is wanting, and nobody wants to touch this segment because of the expected costs involved in it. So we have been talking to IRDA, and Rajatji has helped us with lots of ideas. So we must together take this forward and see whether we can arrive at a product which will be a win-win situation both for the private insurance companies and also for the elderly. So this is one area I would be very happy if you could deliberate and give us some ideas. Third thing is that we need to build livelihoods. I think we have been saying this for a long time, and this year we'll be forming something like about 40,000 elderly self-help groups across the country, and these self-help groups will bring in probably about, say, 4 lakh elderly who are primarily below poverty and primarily from rural areas. I think these two segments don't get adequate attention in our elder care ecosystem, especially in the private sector also. So we thought that we should focus on this 4-5 lakhs to start with, to see how these groups are functioning, will function. The idea is that they will come together, they will select a productive activity or socially useful activity, and then we will stand by them, help them, assist them, so that they would be in a position to make this bring in this activity and get productively engaged in the society rebuilding. So this is one area which we are focusing on. I would keep all of you informed about the way that this experiment is progressing, and as and when it succeeds, I'm sure we can scale it up manyfold. We also have started this elderly re-employment venture called Sacred. All of you are aware of this. Some of you have posted jobs on it, but this has to build up. Right now, that Sacred portal is facing a few technical issues, but we will be able to come back online before 26th of January, and then we also want to bring in some agency, a management agency, which can run this portal on a professional basis. So I will be looking for your support in this, and people who are very good at this sort of a bringing together a virtual employment, a virtual platform for settling employment matters. I think if you can identify good people and then bring them to participate in this bid, which is already floated, that will be very nice, and we are really looking for some really professional management of the Sacred portal, so that all of you feel confident to post the jobs, and then the seniors will be attracted towards the portal and then put in their requests for re-employment. So we are looking at these two ideas very seriously in the livelihood sector. Fourthly, there is a need for all of us to focus on innovation. Now, lot of new products are coming in the other sector. There are lots of startups which are working. In fact, India is fast becoming a startup capital of the world. So we need to have adequate attention on the issues being faced by the elderly. So that requires some sort of a focused attention on the part of the industry, so that some new innovations come. We have floated what is called as a SAGE. Soumyajit and others have participated in this. Not participated, actually they have designed this whole thing. So we have done one sweep across the country, and then we found some innovations which are worthy of promotion, and we'll be soon giving some sort of a capital contribution to these companies. Now we are going to come up with the second round of SAGE, and so I'm really looking at good proposals coming, which will bring some freshness to the elderly ecosystem, and kindly all of your cooperation is actually required in taking this forward. Lastly, that fifth point I would like to state is about the CSR funding. Very little of CSR funding has been coming to the senior citizen segment. So we have just sought the expression of interest from the people who are working on the CSR field to express their interest to come and then work with us in mobilizing CSR funding for elderly projects. So this agency would actually identify elderly projects which are currently underway, evaluate them, and then prepare a shelf of projects. And these shelf of projects would be presented before the companies which are having CSR funds, and they would like to sort of they argue on behalf of these projects, so that some funding, CSR funding, will flow in using from the to the senior citizen projects which are functioning well. So these are some of the things that we are looking, and I'm looking at how your ideas, your thinking, your suggestions can shape up this initiative better. So I just I wanted to be here physically today, but unfortunately because of some other engagements, I'm forced to be away. So my request to all of you is that focus on focus on some of these issues, and then keep coming back with new ideas, and we will work together for better days for the seniors in this country. Thank you very much.
A big thanks to Shri Subramaniam ji for his encouraging words and sharing his perspective, and for assuring us his support. We are also receiving a lot of positive comments from our audience who agree that this is a powerful milestone towards raising awareness on senior care, and believe that it is a collective responsibility to take it to the next level. With this, we have with us as our chief guest today, Dr. Vinod Kumar Paul, Honorable Member Health, Niti Aayog. I would like to invite Dr. Vinod Paul to come on screen and address those who have joined us today for the launch.
Good evening, namaskar. Distinguished colleagues, Shri R. Subramaniam ji. Am I audible? Can you confirm, Julia?
Yes, sir.
Yes, sir, very clear.
Thank you so much. Shri R. Subramaniam ji, Dr. Harsh Mahajan, Shri Pawan Chaudhary ji, Brigadier Dr. Arvind Lal ji, Shri Gupta, Rajit, Ms. Nanki Lakwinder Singh ji, distinguished members of the panel that will follow, and dear attendees of this webinar come an event to release the white paper on catalyzing reforms in senior care, and indeed for this wonderful roundtable. I'm very pleased to be here amongst stakeholders, getting together, thinking together, and having done deep dive, some of you, and in the form of this report, to share that report and that deep dive. This opportunity, I'm truly grateful that you have invited me to be a part of this. A very, very important area of work, an unfinished work, and in a way, a work which is still to be started in full earnest, so to say. You have laid out very well the epidemiological imperatives, demographic imperatives, healthcare aspect, the social security aspect, the mental health and emotional well-being, very, very clearly already in your brief presentations. I would like to very, very warmly thank you for preparing this white paper. Very grateful. If Niti was to do this work on our own, I know how long it would have taken. And it is so helpful for people like us to be able to use the outcomes and the recommendations of this deep, insightful work. So I congratulate Vicky, I congratulate Amtal, congratulate Nat Health, Asli, and above all, as Dr. Harsh Mahajan knows, I always say, bring teams together. And I'm so happy that I am seeing 4+ many other teams in this work and this partnership. So it really makes me very, very satisfied and very overwhelmed by the fact that a very sincere effort has gone into laying a blueprint relevant to the day. And we must not miss the opportunity to take forward the ideas that are crafted out of this deep work. I can also see that behind this is passion. You can feel the passion. I can also see that behind this is also, a holistic thought about the elderly. And in a way, when I looked at the report, the early parts of early versions of the report, I was wondering where is health. Then I understood after reading that actually it is injustice to the elderly, to our seniors, to look at only health. Of course, I still find nutrition is missing, by the way, just occurred to us. Can somebody take a note of it, Nanki? Nutrition, I didn't see very much, but nutrition has to be remembered, not necessarily part of health always. So important. I'll come back to that in a minute. So the first thing you have convinced me is that it is not only about health, it's also about the holistic well-being, and we cannot have a narrow vertical initiative which we may celebrate, which doesn't do the justice from the start, and then we later on add these pieces and somebody will say it's not my job and so on. So thank you for taking a holistic look, and you convinced me that this is the right way of doing it, and thank you for doing it. I'm also very fascinated by the speech of my distinguished colleague, Secretary Subramaniamji. As always, he has his heart at the right place and the mind to find solutions to those problems. And the work that he has done is phenomenal. Task forces, this idea about self-help groups, livelihoods, pushing the frontier, and a lot of intuitive recommendation that you have made are they will find a platform and they'll also find the solutions in that. So I congratulate you. I congratulate him for partnership with you and his own initiatives. I'm very, very pleased, very proud of that work done. I think we cannot also thank enough the contribution by IIPS, by the great LASI study, which for the first time brings forth the true picture of health and well-being of the elderly. So I congratulate and thank also the stakeholders who conducted the LASI study. I got a glimpse of the key recommendations, and I also had a chance to go through them briefly. I would say very relevant, very practical. थोड़े elite हैं, वो तो आप हमेशा ही करोगे. लेकिन we can adapt them to the lower middle class in particular, and the poor. So let me tease you that you have kept that circle which is focused more on the middle classes and above, which is fair enough, which is fine. But this allows us to think more holistically because there are energies available and there are nuances which are applicable to each one of our segments of population. I only have, I will tell you the way forward, but let me just react to some of the points that were, clear synergy of minds and where I would like to make my humble contribution. Clearly an area of innovation, coming from where I have come and connect with DBT and science friends in the science technology institutions and academia, and my great colleague and friend, Dr. V.K. Saraswatji, who's in the Niti Aayog, anchoring science and technology. I think it's one spontaneous area of work for us to do. I will just let us know how to go about doing it. We can have a special grand challenges for the care of the elderly, but we need to have some examples of what are we looking for. So we can do a little more work. Maybe it is there in your report, but we can craft it in the form of schemes to be taken forward in the Atal Innovation Mission on the one hand, other innovation systems, but also, I guess, the BIRAC system and the grand challenges system. So this is very interesting and a very doable aim, and for which the time has come, if not already we are late. So let's work on that. I like to learn from you more about the private insurance aspects of it. What is it that we are looking for? We have been toying with the idea of an insurance instrument which works for the so-called missing middle, and we could not really craft a great instrument so far. We did something which has no traction. So one aspect, as you correctly said, is incorporate everybody in the PMJ system, which is one option. Let it be there, flagged. It has certain issues in the sense that PMJ is moving in a certain way up the ladder, covering a vulnerable population, has aspirations to cover others, but whether to jump by age criteria is an interesting thought. I had that bit of insight earlier also, but an interesting idea. We keep this in mind. At the same time, to develop an policy instrument which can protect the elderly of poor or low income status would be very good. But I must say that not easy to do it, because when you look at their dynamics, their maths, their maths puts us off and our aspiration puts them off, I tell you. Because I have tried to do this kind of a work with the insurance teams. I try to work for an instrument with the banks for affordable loans for the medical students who go to private sector, and when it is 30 lakh, that will be paid after 12 years or 10 years after post-graduation. Suddenly the maths breaks down because the interest becomes so much. So what I'm trying to say is I'm not from that background, but I find it not easy to develop. So I would love to work with your teams and your experts to create a private insurance system. And I can assure you from my own little experience, not easy. Beyond an age, there's nobody who gives you insurance at all. And nobody extends your insurance. And I said I had an option just before it would have closed the window. So we can relate to it. That even when you have the option, it is not there. Absolutely. So I think the issue of financial protection for health and for ill health and for accident is absolute necessity if you can find a way of doing it. I'll be very happy to work with the insurance sector. We will invoke the DFS. They're always there for us, I assure you. So we find an interesting area of work. Let's hope we will succeed in this. I like you to look at insurance model in other countries to see how those dynamics work and how to catch it. So this is clearly a second area of our work. I have some inputs from you on the GST/service tax. Made a note of it. I'll see what I can do on that as your advocate. Your point about CSR, sometimes we need to look at how to channelize this, because it's often, I hear this, but I have personally not found a great success, through me for something that I would like to, right? Always we talk, but you plug it here and you plug it there and plug it there, but I haven't been successful in getting a big CSR contribution for a cause. So I like to learn from you how we can do it. It looks good, but when you look at how the CSR funding happens and who gives whom, you suddenly I find it difficult to navigate. So I'm here to discuss with you how to do it. And of course, my colleagues like Dr. Shri Amitabh Kant and others have much more understanding of this area and many more connections. So we are happy to invoke that, because why not? But then for what purpose? CSR for what? And I'll give you one suggestion in the end where CSR could work. Saving scheme, I think we club it with the insurance because it will be the same initiative. same stakeholders roughly. So we'll work on that. I think on the issues of financial security, livelihoods, very, very important action is being taken by Secretary Saab. I would be very happy to follow him, and hold his hand and give him energy, like all of you, one of you, to make that happen. And whatever we can do in that space will be truly noble. And let's see how we can change the paradigm. Again, I would please keep one thing in mind when we get together. Just keep thinking about the very poor also, because livelihood. My mind goes there. My mind doesn't go to the seniors that they are there in my circle or my family or my friends. So that's the way I'm trained to think. So please I'll keep challenging you and tease you that there looks like some omission. 3 more pages are missing about them. So please don't mind that. So keep that in mind, and maybe you pull in some stakeholders who work in that area in the group, so that it is national, so it is pan population, right? But I do see huge selflessness in the effort. Harsha, I can tell you, Dr. Lal, when I tell you that I see, it is not a very typical, corporate body document. And thank you for doing it. We will be happy to go through. I wish Nanki had explained a few more recommendations, but thank you for laying the pathway for us to think. Let me now make 3, actually 2 suggestions and 1 way forward. Firstly, as a part of primary health care under Ayushman Bharat Health and Wellness Center mission, care of the elderly is bound to be included. It's already listed, except that it is not being yet rolled out, it's being thought, documents are there. And a beginning is being made, a very sincere beginning. It's one of those 12 packages for primary health care. Of course, it will apply also to urban poor through the health and wellness centers. And of course, state governments can adapt. And we now also have money flowing to the 3rd tier through the 15th Finance Commission, resources. They can technically, potentially be channeled also for this area of work, although there are already takers where this should go. But nonetheless, the fact remains that there is money in the hands of the 3rd tier as well. So my suggestion would be that look at that model, which is the NHSRC. And Rajesh may not be on the call today, but I'm sure we can work and see how the learning that you had through the course of this wonderful paper can be connected to that, so that the critical elements are visible the way the program is being developed. The constraint of that program would be that it is meant to be driven at the grassroots level by the team at the Health and Wellness Center, which is a mid-level provider, and 2 A&Ms, and so on and so forth. So it moves in that paradigm, but whatever we can do through that system, which is the footprint of our primary health care, we should do it. We should also think how that opportunity can be leveraged, for example, through telemedicine or through other means. And it doesn't mean that tomorrow there will not be more resources and more people. So we need to make a case. And therefore, aligning it with the primary healthcare, comprehensive primary healthcare model of India would be a very laudable work to do. And let there be, a back and forth understanding of how the thinking can be done, how this can be leveraged. So that's my first part. Second part, flowing from this, it's actually not second, but flowing from this is, one idea for CSR would be that through health and wellness center, care of the elderly, can that be demonstrated in an early scale-up model? You may call it pilot, you may call it early scale-up, so that we have the learning for future models or next model, which is version 2, but more that can be taken to a bigger scale. Why I say so is for the following reason. Say immunization program or diarrheal disease program, the child health program, had very significant learning phase and research and development. Pneumonia program is a great example. Childhood ARI program, great example. Great learning. Everything has to be shown and then only you incorporate. Malaria, bed nets, do they work? They don't work. Who takes it? Is it purchased or given? You have an answer, evidence for everything. Unfortunately, when we are going beyond maternal and child health and infections, the experiences on the ground by way of systematic studies, we call them intervention studies, often they are cluster randomized. They are, of course, community-based. They are, of course, ideally multi-site, multi-country, so that there are collective learning. This part breaks down. It's weak because from the MDGs, we have really not transitioned into SDGs and beyond. For the MDG agenda, a lot of research was available of the 80s and 90s, and then during the course of MDG. So you had home-based newborn care, sepsis treatment of the newborn, intense studies, and kangaroo care, etc. Diarrheal, of course, disease was even more so. But as you move into, let's say, care for hypertension, we screen, but we don't have wonderful models of effective control at the individual, at the household, at the community. So there is this gap that for the priorities of the day, for which India cannot wait anymore, and the world cannot wait, the evidence and the systematic experience and learnings are in low supply. So I could request your partnership to think whether now using CSR or other resources, when working with academia, is there a scope for demonstrating a primary healthcare model of the care of the elderly, fashioned by the Ministry of Health, helped by other stakeholders, and delivered through the available health system with capacity, with some resources, but it helps the poor. It works. It works for the lonely elderly who's in a village, a woman, let's say, who's just has neighbors, and so on. And so can we think about what should be the elements of this? Would it include only heart care and anemia, or will it be also care of the skin? Will it also be care if there is a disability? Physiotherapy? I don't know. So we need to think through. I want you to think. You are from the medical health fraternity, and therefore, who will think if you don't think? And obviously, there are academics out here, and they should spread this word. Where is that model? We are saying it's a huge problem, but then where is academia looking at creating the solution and testing the solution, letting us know the needs, the package of interventions? Maybe we have that, but then showing that it is scalable, it's affordable, it is doable, and it has desired outcomes. So that's one. So early scale up for the care of the elderly model. I'd be very happy to remain a part of the discussion on this. We're very happy to work together with you. My second suggestion is to a telehealth model for care of the elderly. A physical model for care of the elderly should move, should accelerate, should be developed, should be adapted. There could be multiple models depending on the setting and depending on the resources. It doesn't have to be only through the health and wellness center. That's a core paradigm, but there's so much more beyond that that can also be done. There can be care also at primary health center, district health center. Local bodies can do something and so on. So that's just the core around which other things come up. But having said that, let that happen for the rich and the poor. But the care through telemedicine cannot wait and should not wait and need not wait. So I urge you now to discuss whether we can set up a telehealth model to begin with, let's say for urban elderly or a peri-urban elderly. Just because when we are developing this, of course, telecall can come from anywhere, but then it can be driven by partners like yours in a public-private or a private-dominant public-supported system. Can we create that in the spirit of bringing together the stakeholders? We have learned how this task can be done can be crafted over a short period of time from the COVID times. Telehealth is there to stay. Telemedicine is come of age. So and then, again, the point is, it is not just picking up phone and talking. What is it that standard, what should be part of the standard advice on various issues? How should this be conducted? Who are the best people other than the doctors who should form the front line? It need not be doctor driven to begin with. It should not be. It is unnecessary. Special counselors? Can we have nurses? Can we have other counselors? And then, of course, you talked about skilled people who go home and provide care. That's another aspect to it. That's the outreach part. But I'm saying the question that the elderly ask are ultimately going to get into a few boxes. How do you respond to that? How do you provide that care? Backed by general duty doctors who can be specially trained, and then the specialist if required. There are no specialists, by the way. How many seats of geriatric MD are there? So we have to depend in the near future on the non-specialist. And why not? What is the problem? Right? There can be a model which does not depend on. I don't think care of the elderly in the developed nations is delivered by the geriatrician. It's an interdisciplinary, multidisciplinary task in some role for geriatricians, maybe in patient settings. So I urge you to think about creating, shall we say, we can even call it national network, or we can say telehealth networks. The issue with telehealth is the language, so it has to be some language-based networks. But there is a standardized advice, there is an evidence-based advice, there is an advice into which we can also weave in Ayush to the extent if the individual accepts, and so on, and a general care and emotional support, and taking care of prevention, how to walk so that you don't break your femur, and so on, and the appliances that you talked about, the low-cost appliances, and so on. So here, these are my two suggestions to work on essentially in the space of primary care, and you all also talked about essentially the primary care. One is through formal health and wellness center comprehensive primary healthcare model, but not alone just thinking what should be done, but how we can do it on a medium scale nearby. We don't have to go to every corner. Okay, we can do nearby so that we can all implement a program and demonstrate that it works in Haryana, it works in nearby Rajasthan, it works in Karnataka if you have a set of friends there. And second one is not to delay the creation of a telehealth system, support system, which we can start in 100 days before the 15th of August. Let's create that model. It doesn't again have to be, as I said, with a pan-India footprint to start with. We can do 5 nodes in 5 cities, 5 regions. Okay, so let's think about it. My last point is with regard to the way forward. So I look forward to interacting with you. I have not covered your other recommendations for which I may have a role, may have a possible responsibility, but you can also involve some people who are missing today around the table are those who are working at the grassroots level, some NGOs, some people who have a sense of this from the ground. I like to see them to be also around the table. Please invite them and get them. And that will only help us make decisions and make effort which would be relevant to a very important part of the pyramid. But thank you so much for the opportunity. I look forward to connecting. Let's create that group and have a follow-up meeting. I promise we'll do a meeting. I look forward to that meeting, and where we could then see, product by product, or shall we say, some of, I will obviously not in my domain to cover everything that you have represented here, but certainly a few domains where I can make contribution, Neeti's health vertical do the contribution. I will be very, very honored to take that forward. My grateful thanks to you, and thank you very much for associating Neeti with this initiative. Jai Hind. Thank you very much.
Thank you so much, Dr. Paul, for your kind words and appreciation in sessions and for ensuring us your support in this initiative. Now, we will launch the white paper in the august presence of Dr. Vinod Kumar, Csr Subramaniam, and all our eminent leaders. Thank you. And for our audience, you will be able to access the complete white paper from the websites of NatHealth, ASLI, FICCI, and MTI. With this context in mind, we will now move on to the panel discussion. I would like to invite our moderator for this session, Dr. Rana Mehta, healthcare industry leader and partner, PwC India, to take the screen and introduce the panelists.
Thank you. And it's after listening to all the experts and especially Dr. Paul, we all invigorated and really we are honored that you've appreciated all the hard work that's gone in. I have an amazing panel which will look at all the components. We have Dr. Dinesh Arora, who's a senior healthcare expert, and many of you may remember he was the former deputy CEO of the National Health Authority. Dr. Sunila Garg, who's very well known in this space, Professor of Excellence and the National President, AP, SM, and OMAG. Dr. Om Manchanda, Managing Director of Dr. Lal Path Labs. We also have Raju Narayan, who is a senior healthcare specialist from IIT, and we're really thankful for him to have got up so early for this. We have Mayank Batwal, who's the CEO of Aditya Birla Health Insurance Company Limited. And finally, we have Dr. Karthik Narayan, who's the Managing Director of Atulya. To have this panel.
Your voice is breaking. Rana, your voice is breaking.
Is this better?
Yes, better.
Yeah, I think you can put your video off. Yeah.
Sorry about that. So thank you. And so I think one of the things as we looked at elderly care, and here I'll try to start quote. Mahatma Gandhi said the true mirror of any society can be found out how it treats its most vulnerable members. And I think one biggest component now, increasingly as we've seen, are going to be the elderly. A couple of years ago, I'd gone to Japan, and when I was in a meeting, people said, forget about tsunami. We have a silver tsunami here in Japan. We haven't reached that, but we have to make sure that when we reach that, we are not in a society which is aging and not able to really fend for itself. Also, I think one of the recognition, the elderly are not a homogeneous, it's a heterogeneous group, which the brought out. They're at various ages, your abilities, your needs are very, very different. What it also brought out is, we don't have the skill sets of the elderly. We always talk about a demographic dividend. A lot of skill sets which the elderly bring, and as you find people living much longer, these can also be harnessed. And what the pandemic has also taught us that it can be harnessed in a digital way. One of the other things, while the report is not rightly not only confined to the medical part of it, is how do you provide financial accessibility for people who are, that becomes more important. So, we're glad to have Mayank here who will talk about the financial accessibility from a payer perspective. And finally, also, I think it came out again and again that, we have the elderly, we have the skill sets amongst doctors, amongst givers to look for them. And I think that will really be an important part as we go ahead. I'll start with Om. And Om, you've been a veteran of glass trade, and you've seen this whole area evolve from a period of the last 20 years. And you clearly were telling us that there are very different requirements for elderly. You're also giving us a lot of insights, especially when it comes to the diagnostic side, how their requirements are very different from you and me. Om?
Thanks, Rana. So I think when this topic was given to me, I was really wondering how to really go about putting down my talking points. What I essentially did, three areas. One, of course, the report that's been released, and I really won't go deeper into that because everyone has spoken on that. The second area, I thought probably I'll go deeper into the data that I have internally and try and see what's really happening in this age group, which we normally don't see on day-to-day basis, but some insights I've got, so maybe I'll like to share on this panel. The second interesting thing I did was, last we spoke, I got some 20 home collection boys of ours who actually go and collect samples from people's homes and tried and understand as to what are the issues they are facing with this age group. And pretty much first-hand insights, as Dr. V.K. Paul said, let's try and get people from grassroots. And I'll try and get you the feedback what I gathered from them verbatim and probably repeat the sentences as they mentioned. So let me first touch upon the testing side of it. The interesting thing, I think the report says that by 2050, 20% of the population would be 60 years and above, right? As I see our business, actually 20% of our current revenue actually comes from 60 years and above. So while the numbers may be higher later, but the same numbers in terms of medical needs are already happening. So it's not something which is going to happen 30, 40 years, 30 years from now. It is actually already happening as of now. I also tried to get a split between gender in terms of males and females. It's quite sort of similar, but it's more drifted towards male. 55% of tested is from male sides and 45 is females. Then I looked at top 3 tests which are being ordered from this age group. What I really find is a preventive health checkup is the #1 test which is ordered. So primarily looks like in this age group, annual health checkup is a basic requirement. I think any product innovation that we do either through insurance or even what we want to communicate, I think annual scan must be a ritual for any age group, any person above the age group of 60 years and above. The second largest test I thought I found very intriguing, probably one needs to understand, is kidney panel test. And I presume it must be emanating out of these two non-communicable diseases like hypertension and diabetes, eventually leading to kidney issues, is a big area of concern. And third is CBC. I think it's all because of multiple issues. I think it's a very common test ordered in many situations. And for males, I think PSA I found is a #4, prostate. And for females, some 2 unique tests, which is ovarian and breast cancer related tests. I think that those are the issues that I see on technical side. I'm sure when we work on what are the measures we need to take, we'll incorporate this. But let me now go to the non-medical side, interviews that I did with home collection boys. I think those points everyone made. #1 big area which is coming is lack of social interactions. This group is highly, highly lonely. In fact, people said that time which they take for home collection for elderly is much longer than what they take for younger guys. So I said, why does that happen? It really happens because after the sample collection is done, they want to chat. They want to understand what's happening in their personal life. They tell what's happening in their personal lives. So unless they involve in the social interactions, the whole entire process of home collection is not complete. They even go to the extent of actually serving them breakfast as well. Some of them actually said, we come and eat and have a cup of tea with them. So I think what's coming out is that this group is highly lonely. And whatever program that we put together, either from private side or government side, this piece has to be addressed very quickly. I think the second area that's happening is India is a growing economy, and one has seen the generation gap is very, very wide, both financial status, lifestyle, habits and attitudes. Younger age group, they don't mind having a glass of wine or drink in front of their parents, so which is something that is not really supported by them. They don't like all that stuff. So I think this gap between this generation and the older one is creating. And the word actually somebody mentioned to me is that apnapan is missing. They really want to see that. I think someone mentioned that baatein hoti hai, baat nahi hoti. I think Pawan mentioned this comment. I think which is very, very true. Third very important area, which probably has not come through this conversation, I want to highlight, is that most people in this age group are struggling to keep up pace with the technology. Many of us who are in corporate world, private sector, every now and then we are developing all kinds of apps and we are pushing the whole world to move digital. What has come out very clearly in my conversation with these guys, that many of them are really struggling to operate. While we think that because of WhatsApp, everything is there, they can always operate on this. But at least my group suggested there is a huge skill gap. They find it very difficult to book order online, download their report, and they actually take a lot of help. Beta, can you do this for me? They still go back to the old ways of working, dialing up, calling up someone and taking help. I think what probably can be done is to really, how do you bridge the skill gap? Because the world is moving very rapidly and people in this age group are falling behind. And actually, I'm wondering when I reach that stage, I know what will happen. I'm going to reach soon as well. So I have a couple of suggestions to make, Rana. I know I probably will have to drop off early because I have something to catch up at 4:30. I have two concrete suggestions. Suggestion number one, can there be a TV channel sponsored either by the government or by private sector or together, if not exclusively, at least some programs dedicated for healthy aging? We need to, in fact, it reminds me when I used to work with Hindustan Unilever, I don't know whether they still have this program. Anybody who was retiring 2 years before was put through a course called Post-Retirement, How to Manage Your Life. I think there is a need for a package like this so that people are really taught, counsel as to what is the way of post-retirement healthy aging. Second area is vocational courses to pick up some of these tech-related knowledge which is required. And lastly, I would say it's not only, I think sometimes we feel the problem is with the older age group. I think there is a bit of a counseling and education required for younger generation as well. And all of us can put ourselves in our personal experiences as well. At times we tend to believe or we tend to blame the problem is the older age group because they are very rigid. They are very stubborn. They don't listen to this. I think there could be an issue to be at the younger age as well. Is there any helpline or counseling required for even younger generation? They need to be prepared as to how to handle older people at home. I think this is what these are a few suggestions that I can make. I'll be there for next maybe 10 minutes, but I may just drop off, Rana, in case you want to come back to me for second round. Thank you.
Oh, thank you, Om. I think that was very, very insightful. And I think what we really require those insights was, it's a very proactive approach of an early recognition of what the elderly actually require. It's not that we go make something and then realize that this will work for them. Like a simple example of even an app which seems very straightforward to us, it is difficult for them to actually negotiate. Great insights. I'll next come to Dinesh. And Dinesh, something we heard right from the beginning, was clearly, if we are going to go and build this ecosystem for the elderly in our country, we need to have something which unifies it. It's very siloed. You've seen how it sits across ministries, how it sits across the state, it sits across the and the time is right for a national aging mission or a national online senior portal. What do you think, given your experience, will be the building blocks we should put in today so that a decade later, this is a seamless change?
Thanks, Mr. Rana. I think this report couldn't have come at a more opportune time. I think just to mention some stats for this. For 0 to 14 years of age, we have 3 ministries working on this. Hall of RCH, MCH, a lot of attention. So in 2050, our seniors will be more in number than 0 to 14 years of age in children. So that's a point which is so emphatic, and right now is a time where we start acting on it. I'm so happy that Mr. Subramaniam mentioned as a national report coming. So it's an initiative of public, private, all together along with the government to come up with such kind of report. Reports can improvise, but it's important to create a buzz, and this buzz is being now created right now. As I hear people, of course, this section of senior citizens will require special attentions, like for faculties going down, aging, health becoming frail, loss of financial resources and independence, and of course, what we also called as feminization of aging will be there because women have larger life expectancy. Ruralization of aging will be there because still India lives in about 60 to 70% people still live in rural areas, and of course one more issue which Om tried about, Om said about socialization is a loss of spouse happens. About 55% women in more than 60 years of age have lost their husbands. So that's a problem is real intact, and I'm happy that you have touched certain areas today with the buzz being created. I remember when we were SDMs and Mr. Subramaniam is there, the Maintenance Act 2007, which was passed, I think when I was SDM Ottapalam, we did the first judgment there where a son was asked to go in jail or keep your mother happy or give 5,000 rupees per month in her bank account. So that was done in Kerala and Ottapalam. Today, the Maintenance Act is done so well in many of the districts in Kerala, which people are aware of this, and parents are likely to go to the SDM or the sub-collector there just for getting the maintenance, and or the sons or children can be punished. So some small increment changes have happened, which have an impact. But I think now is the time where the government shifts into a generational change for this aging program. And I think one way forward could be some kind of an aging mission, or maybe aging mission or mission for elderly. What we are looking here is active aging in place, where people can contribute, have a sense of independence, fulfillment, dignity, as well as staying in their own home community, where they were more comfortable with. And that should have a governing body headed by perhaps the Prime Minister himself, if we are lucky to get it. If we have our senior colleagues, Mr. Paul and Subramaniam Sir, Secretary Social Justice, or maybe by the Minister of Social Justice, and having a conglomeration of different ministries who can contribute. For example, I can see two major stakeholders, our Ministry of Social Justice and Health, but I'm so happy to see that it's not only from the prison of health or disease, but also from side of infrastructure, enabling Panchayati Raj to look after them, rural development, Ayush. So all these will have a role to play. Some kind of an aging mission is the right time to begin with, and government needs to take a lead here. This buzz which you may create now needs to have some kind of action. And there are certain doables which I can come out of my hand. Like for example, PMJY has been a very successful scheme, Ayushman Bharat. Why not take all more than 60 years of government, state government and central government come together to finance their secondary and tertiary health? Why not have a system, something like NHS Direct, which is basically what Mr. Paul was saying, a telecounseling. And it starts from basically from counselors, nurses, goes to doctors, and then goes to specialists, depending on which kind of hierarchy. Imagine a senior citizen having a vomiting in the night. Whom should he talk to if he has nobody to take care of him or her? So that's something which can have a lot of impact. So there have been certain incremental changes, but I think right now is the time to go for a regulatory framework. A few things, how to decrease out-of-pocket expenses, new financing systems for healthcare. And healthcare means not only for disease, but even for their wellnesses. A framework where public-private partnership could cater to. And this could also mingle in what we call as CSR. Capacity building of health staff is perhaps one of the most important things which we should start now, because it will have some lag when the results start coming out. So these are some of the things which I think government needs to fix in, along with accreditation standards for old age, treatment bundles, how they're standardized, the standardized care SOPs, which need to be formed and which can get more of a NABH type of an accreditation. So a stamping comes with government coming in, the impact comes with government loading in. So I believe there's a huge role for government to come in now with the private sector with the philanthropists, with the not-for-profit sector, together to, harp or to incentivize, to align these incentives which are being flowing around, to have a care elderly model which have been institutionalized right from the government of India to the state governments to up to the panchayats. And Kerala has done this. So like in Kudamshri, as well as in the palliative cares, which Kerala has been a model. I think these are some of the good steps which I will like government of India and the state governments to see forward based on this. Thank you.
No, thanks, Dr. Dinesh. Very important. And I think the key takeaways is we have the buzz today. We should not lose it. The second is let's put a framework using both the public and private sector. And finally, I think a lot of things you said, how do because the time for action is today. If we delay it by a decade, then we could miss out. And maybe like we see in the US, the cost of healthcare goes so high that it becomes unaffordable.
But just trying to add also, I remember the Hong Kong tried to follow a Japan model and they could not do because the financing was less. I think government will also need to up its financing on elderly. Japan spends nearly about 1% of the GDP on elderly care, and we spend about 1.3 on the whole health. So I think there's a time also where government will also need to have more share, but of course, we need to come up with a plan and how it happens, and it has to be done in phases. Thanks.
Yeah, and I think the point you said that, if there is an aging mission led by the Prime Minister, it will obviously get top attention, it'll become part of our national discourse. We don't talk about elderly care, right? So how do we bring it as part of the national discourse? I'll next go to Dr. Sunila, and I think everybody's been talking about it. We have elderly people, and this is the number we're going to have. These are their problems. But I said we don't have the people who can look after them, whether it's doctors, whether it's nurses, whether it's caregivers. So how can we build this cadre right from so that a decade later we are not struggling to for these resources as we do in other components of healthcare?
Mr. Rana, thank you so much for asking this question. And in fact, Dinesh just talked about it. Let me tell you, India is one of the first countries in the world to have the most robust program for national healthcare program for elderly. And one of the important components of the program is capacity building. And I had the pleasure and honor to develop the capacity building modules, which are already developed and standardized, along with collaboration with WHO, which is an accredited program. Here, each and every, that means the materials and facilitators guides have been prepared for medical officers, mid-level workers, grassroots level workers, which are already focusing on, primarily we are talking about, not only the, a specific role for the specific manpower, what they are supposed to do in the community, and that came with the perspective of Ayushman Bharat. So let me tell you that the capacity building materials are already there. So it's only that by the end of 2019, they were prepared, and by the time COVID came, so this took a back seat. And as you talked to one of the very, I'll say a powerful lady, Dr. Gauri Sen, she already was a part of this modules along with WHO. And another thing is that we already, basically need to look at that what we are lacking is the private-public partnership, where we need to look at that part. But, along with these capacity building materials, we do have a open or we'll say a distance program of IGNO, which is run by which Dr. Paul was pointing out. It is being run at many academic institutions. That means the medical colleges themselves are running this postgraduate diploma program, for geriatric medicine. And this is, meant for MBBS doctors, which are, the basic doctors. If MDs come, they're most welcome. But this is a specialized this thing, which also, sensitizes them to, primarily the healthcare needs of elderly and all that. So you see, under Ayushman Bharat, that thing is taken care of. But, what is required is the regulatory framework for the high quality delivery, with the help of skilled manpower and along with digital infrastructure. What has been stressed again and again is that we need to now, again, the pandemic has highlighted the need for, digital infrastructure that is there. But also we need to know that WHO basically focuses on active and healthy aging, and Government of India focuses on aging in place, which could be supported by creating a home environment. That is one thing which is the need of the hour, because after some time, we cannot let the systems be overwhelmed with the elderlies, which can be easily managed by the home care. And in this regard, let me tell you, I also had the pleasure of preparing home health aid also for the grassroots level workers, so that, we can minimize or we can rationalize the hospitalizations also. So that is another important component which we need to take into consideration, and need to refer them and incorporate it in our own this thing, that we already have got these materials. So already there is a robust reference in our this document, white paper, about the National Healthcare Program for Elderly. So that is another important thing. So we need to look at the home-based care with the help of skilled manpower, and so that, people who are hiring, the manpower, except when they're hiring from the big hospitals and all, other manpower is all untrained manpower. So we have to make sure that, in future, whatever manpower we hire for our parents, for grandparents and all, they're all trained people. They not only look from the perspective of fitting in an assistive device, but they are very vigilant about the holistic care of elderly. So second, this thing is, we also need to have capacity building in terms of, supportive care, which is far beyond medical care. That means the non-medical care, or the care of bedriddens and all that, and then medication and the nutrition part, which was mentioned by Dr. Paul also. But, our National Nutrition Mission and the National Mission for Aging also has got a nutrition component, which has been missed out somewhere, but that is there in our white paper already. So we must make a reference. So these points are already there, but we need to expand onto that. And another thing is that now we are also focusing on senior daycare also. Now the state governments are also coming wherever there are working parents and all that, or working people. So they leave their grandparents for the daycare at these centers. But then the quality and the capacity building of these people also needs to be ensured. So our availability of enablers is already there. We have specified trained manpower at the grassroots. We have geriatric physicians and nurses. But only thing what worries me is that by 2025, our demand will be for about, 40, almost we'll say that about 50 to 60,000 workers. So where this workforce comes from? This workforce comes from rigorously implementing the program, which has an inherent component of about, capacity building, and that is rolled out in 528 districts of the country, out of 728 districts, envisaged, and 112 aspirational districts are also part of this. So that is one thing which we have to take into consideration. But we also somewhere cannot deprive the people of the specialized care. So our 8 regional centers which are there as part of policy, they're also focusing on 16 MD seats also. So we have to push this through National Medical Mission. So overall, we are focusing on capacity building in a big way. So also I have to make a plea that National Action Plan for Senior Citizens 2021 has an integrated component of health and nutrition, which has to focus on reforms, intervention, and address all types of healthcare, including telemedicine and digital care. Again and again, you see the need of the hour is telemedicine and digital care. From, I think, last 10 days, I have been viewing the projects with ICMR. And, every project has a focus on impact of technology and all that, but I could not see a single project on elderly care. So that's where we need to create a demand with the help of Indian Council of Medical Research and all, Dr. Paul also made a mention that we need to create a demand for this kind of project where role of technology is really highlighted. But also there is a need to focus on, create a cadre of volunteers, because I remember when we were rolling out this COVID control program for the urban, peri-urban, tribal, rural areas. So we had to rely on, people were very scared to come and talk to the, healthcare facilities. So we said we will create a pool of volunteers within that particular setting also. So here also, whatever setting it is, whether it's an urban setting, rural setting, or a, kind of a deprived setting, we need to create a pool of volunteers. We need to have, informal, caregivers. So informal and formal, both kind of caregivers. We need to look at, awareness of elders in the society. That is through different curriculums in NCRT, SCRT, or Directorate of Medical Education. Then we need to have, also, as I said, the specialized cadre. And then another thing is that, every time in school and colleges and all that, we need to talk about this elderly care. So I think capacity building is one of the key pillars to our ecosystem, which needs a strong attention. But we need to look into, lot has gone into it. We need to dig out of that, and we need to revive that, and we need to put it on the track, because this is the right time to talk about the elderly care, because 2030 is also not that far. Thank you so much.
Yeah, exactly. To be a lost decade, like you said, 2030. I think, and what you said, some of the building blocks have been thought of, but they're just not to scale. We need to scale it up. And what Dinesh said, evidently this requires funding over a period of time, because it's not going to grow. Raju, I'll come to you next, and thank you first for joining it. I know you're sitting in DC at a very awkward time, but really appreciate that. I think some of the problems which India is facing, it's not alien. We have done that. They have an aging population. We in fact have one of the youngest populations, so we are lucky. But I think the whole idea is to be very proactive and think of what will happen in the next 2 decades. So from an IFC's perspective, and especially from an investor perspective, it's also right to get those investments right. And as we build this senior care ecosystem. So what's been your experience, both globally, and I think specifically you've had a lot of experience in Singapore, which has a model a lot of countries want to emulate.
Thank you, Rana, and thank you for this opportunity. I think from where I sit, when I look at it globally, one thing is very clear, that the problem or the issue is common across the globe, but the solutions could be very different from country to country and market to market. And when I listened to some of the previous speakers before the launch of the paper, 2 key words that which I could take away is, one is holistic and the other one is a national solution. This is the fundamentals of this whole elderly care space, because people are still not thinking it as a holistic approach in many countries. And many countries also looking at it as whether it is a government problem, private problem, or who is supposed to solve it. So that mindset needs to change. So it has to be a national solution, not a government versus private, public versus private. It has to be a collaborative thing. If you look at the age structure of the population is changing, it's changing at a very unprecedented state across the world, right? In 2020, 21, just to give a perspective, we have around 750 million persons age 65 and above. So that's a huge number. And the challenges associated with elderly care, as I mentioned earlier, it's not unique to matured market, developing market. No, it's not. In fact, many countries are actually facing the double burden. You have a falling fertility rate, and then you have this aging population. So that's going to be a huge challenge for many of the markets. And on a lighter note, when I talk to my colleagues and my healthcare professionals, people always ask, who is supposed to solve this problem and whose problem is this? And I always tell them, this is a problem we created ourselves, so we better solve it. So what do you mean by that? Because, by modern medicine, we have actually managed to provide greater accessibility, better quality of healthcare globally. Infant mortality rate has, gone down. So longevity goes up. So this is a problem which we created on a positive note. So I think we need to make sure that we can't just create the problem and then leave it there. So we need to address how we want to take care of that space. And if you look at, again, globally, between 2010 to 2050, the rate of the proportion of aging population versus the total population is changing dramatically. In Brazil, it's going from 7% to 20%. In China, it's going from 8 to 24, and Russia is 13 to 20, and India is 5 to 12%. So that's a huge problem. And when we look at, and then I talk about the holistic, what I mean by that is, today most countries are looking at aged care. They have facilities for what you call as assisted living. But I think what elder care needs to happen, what needs to happen in the elder care space is to move from assisted living to independent living. And that can only happen if you look at it holistically. So if you need to look at holistically, the four buckets which I always talk about, when you look at elder care is the clinical well-being, the physical well-being, the mental well-being, and the social well-being. I think some of the speakers have previously touched on that, but I think this is very, very crucial to that. Which means provision of elder care can range from a simple, real estate play, providing just infrastructure for community living, to a sophisticated, specialized residential clinical care services for the elderly. The elder care sector is an ecosystem comprising of many stakeholders. You have the government, the private sector providers, the payers, the insurance providers, social community organizations, collaborating effectively to meet the varying needs of the senior care. The other important aspect outside this holistic is actually the financing part of it, as many of us touched on that. See, universal health coverage, which we talk about, and the social and employer-sponsored medical insurance program today would very much address the care for the acute medical care, but very seldom they look at the aged care population. So the elderly care is rarely insured. For example, for chronic conditions in geriatric patients such as dementia may not be covered under the UHC. So I think this is an area which we really need to pay attention to. Institutional long-term care costs more than most population can afford to pay. Thus, most of the need in such care continue to depend on family and community care as well. So when IFC as a developmental investment organization, when we look at elder care across the globe, we're putting a lot of efforts now to look at opportunities for private sector investment, collaboration, and working together with the public and the government to do that. And so the key thing is the demand for integrated care model for elderly care. I think that's what we really need. And it has to be sustainable from the funding mechanism, from the business perspective, because I know the intention is very noble, but when you look at it as an investment, it has also got to be sustainable as a business entity. So I think we need to work towards finding solutions for that. And technology we talked about, and technology is going to be a huge enabler in getting some of this sustainability and accessibility to fill those gaps. And again, the other most important thing, my last point, is actually the regulatory framework which we talked about, because today that is missing in many countries. And the biggest challenge because of that is, if you do not have proper regulations for licensing, operating, and managing the quality of these elder care providers, what happens is people always take the safe route, right? So many providers would stay providing very low and generalized care because you don't want to get into the liability of care issue when you want to provide the continuity of care. So I think that regulation is very important so that people can provide better, deeper, quality care for the elderly care. So all these needs to come together in order to get this space into a very sustainable long-term care model. Thank you.
No, thanks, Raju. I think you brought out a lot of things, right from how do you do it holistically, a lot of things about how do you put in the regulation at the right time. And, how do you really foster innovation? Because, that is going to bring in both investment and the best talent. So you need to make it viable, sustainable, and really an area within healthcare which grows fast. Next, I'll go to Mayank, and I think this is going to be most interesting. So Mayank, we've right from the beginning, everybody spoke about, in India, whether it's food, whether it's white goods, whether it's education or healthcare, accessibility is always limited by affordability. So unless you get the affordability right, it's just not going to happen. And here in healthcare, in the elderly care ecosystem, we're talking about two components, but also non-medical aspects of care are equally important. So as an insurer, how do you see this, and how as a country we should really make this pan out in the next decade?
Yeah, thanks, Rana, and really thank you for this opportunity. I'll try and cover this in three parts. You spoke about access. You also spoke about affordability, and also as you look at financing, I mean, what should that cover? Because that's very important, and we have heard the word holistic a lot from everyone, including Raju, previous panel member. Now, if you look at senior care, I'm talking right now financing of healthcare, because elder care is a lot more than just healthcare financing. The issue is that in a country which has a population of about 65% below the age of 35, the bulk of the people who are who are buying insurance is above the age of 35. There is definitely a problem, because by definition, there is an element of subsidy in insurance, because if people pay for their exact condition, then it becomes unaffordable, which is exactly the problem that we are facing in India. That as senior care people try and buy insurance, it becomes too unaffordable, and with age it keeps becoming a bigger and bigger problem. So we have to somehow find a problem of getting a much larger part of the younger population into insurance. So that there is an overall I don't think so we can go to an extreme model like what, let's say, for example, you see in South Africa, where there's a community rating in insurance for the entire population. I don't know whether we can afford to do something like that, especially when the awareness of risk is so low, and willingness to pay for risk is so low. But we have to find a way of creating a larger community pricing to make the insurance more affordable, and therefore we have to find a way. I don't know whether it's by mandate, whether it's by higher tax incentive, but somehow we have to make more people in the younger age group buy that, so that we can afford that. I think that's clearly one answer we have to find to this whole problem, if you want to make the whole thing affordable. The second one is that, as you said, therefore, assuming that we create access, how do you make it affordable? I mean, one solution is to get the younger people so that there's an element of inherent subsidy to some extent. But I think, what is insurance finally priced for? Typically, there are two key elements: a cost of healthcare delivery embedded in it, and also the distribution costs. So I'm assuming that we can find a distribution model to make it more efficient, let's say for senior care. Let's say the way PMJ runs today, we can find some similar model for that. Let's say we can cut it down. But we have to also find a way to cut down the healthcare cost delivery for the senior care. And today, because we heard some of the panel members talk about the fact that proportion of costs being incurred by that community, and it will keep increasing. Now, I heard Dr. Paul mention earlier, and I even heard Mr. Rora mentioned earlier, that I think we have built a beautiful infrastructure of PMJ. Is there, and I think whilst there has been I think a wonderful effort now being put in place by Niti Aayog in the form of leveraging that for missing middle. I think there is more conversation that can happen around that, and I do feel very, very strongly that we can find an answer to at least to the lower income class of people, where affordability is a genuine issue, of leveraging that PMJY infrastructure, both the relationship, the technology, I think the fraud and risk management, which is a big issue in insurance today, because 15-20% cost is going in FW, fraud, waste, and abuse. I think that program that has been put. So there are lots of building blocks that have been put in place under the PMJY scheme, which can be leveraged for at least the lower income category of the senior citizen population in India, to find a way to provide them an affordable funding solution. I clearly believe in that. So that's the second thing I think we must try and put in place. Now, the third aspect is that when we look at insurance, and you spoke about that there are non-healthcare, and today what is covered by insurance? Medical health, hospitalization expenses. Healthcare is not just about hospitalization expenses. In fact, for this particular age group, it is a lot more than hospitalization. There's I heard Om speak about, minimum regular annual checkup for this age group. I mean, my parents, they stay away. I mean, if they don't go through that annual checkup, I mean, how do we know what's really happening to their health? And there are many other such expenses that have to be incurred, which is outside the hospital. So we have to again find a solution to the coverage of out of what is called OPD, the out of hospital medical expenses. And there, I think one of the solutions that has been suggested in the paper that we're given, which is the whole health savings account concept. How do you start putting money aside from an early age, so that money, and there could be other ways of, again, incentivizing that pool of money, which can be used at a later age. There can be norms for which that money can be used, but you have to find, because at the end of the day, Rana, that part of the expense is not truly insurance. It's not a probabilistic expenditure. It's a real expenditure. It has to be incurred. In fact, we must encourage that age group to go and have their annual checkup, incur that expenditure, get to know what's really happening to your health. And therefore, for that, there has to be some kind of a funding mechanism for people who can afford it. And I think why can't we find a way to create that? I mean, today, if insurance tries to provide that solution, the 18% GST itself will kill that solution straight away, because there's no way, it is affordable, assuming that you can find a way to reduce the, distribution cost to minimum. So I think that is another thing, aspect that we can, we should look at. And definitely there is a need to create that fund for the senior care. And for the lower income class, again, I'm hoping that, and it was very encouraging to hear, Dr. Paul say that the whole mission of primary care through the 150,000 health and wellness center, because that is, if you ask me, I'm actually even more excited about that health and wellness center initiative than the, whilst PMJY itself is a great initiative, but that component is even bigger, can have a bigger impact, because primary care is missing to such a large extent. And the moment you go to people who can't afford healthcare, primary care creates so many more problems, and it complicates so many more issues, whether it's in rural area, whether it's even urban poor, etc. So I think we can find answer to each one of them if we leverage some of the work that has already been done. And I think the wonderful work under PMJY, plus some new policy regime, some aspects have to be thought through in terms of how do you bring larger pool into insurance, plus create some mechanism for creating a fund, a pool of fund aside for future healthcare need for people who can afford. So, I mean, of course, I can talk for a lot more, because this is something that I'm very passionate about, and we work a lot in this, and that was the reason why we loved the opportunity to work on this paper. But in the interest of time, that's what I'll say for now.
No, excellent, Mayank. And I think, like we've heard, that there's to be a holistic approach. And holistic approach. There'll be various components which will come in. And at the end, I think it's also about saying who's responsible for one's healthcare, right? Is the government responsible for your care? Is the employer responsible? And finally, the best, if you have a proactive approach. So can the elderly actually have a proactive approach? And can we make sure that that accessibility becomes easier for them, either through technology as well as in the financial paradigm? Some of them can really be actioned, because the health savings account, we've been speaking in India about it, but it hasn't been actioned. Finally, I'll go to Karthik. And, I think we all ones who've been talking more about policy at a higher level. Karthik is actually running something for senior living players. So Karthik, given your experience, we like to actually know what have been some of the roadblocks as you try to build scale, because that's very important. We don't want to have we have with hospitals, where typically our hospitals are subscale, and it doesn't create value either for the provider or the payer or the customer. So how do we make sure that we don't make that mistake on the senior care side?
Thank you, Dr. Rana, for asking that question. While we are all talking about the industry getting shaped and regularized, I think we should also be mindful on what's the impact is going to create on entrepreneurs who are coming into this industry to be a solution provider for seniors. I think the current environment, I wish it is more positive, because it is a little bit uphill battle if you want to be in this space, because of the regulatory clarities are yet to be discovered. So that is something it'll be very beneficial if we have like other industries, especially on the infra side, where they have a single window clearance for emerging and motivating people to get into investments or into businesses. That'll be nice to, because today entrepreneurs are not fully inclined to get into the space. They feel it is it's a lot more burden, because for the simple fact there is no clear regulations. But I think with that clarity and with more a model similar to a single window clearance, I think a lot more players would come into the industry to help the seniors. But parallelly, there are currently many players still, right? But the problem relies where one side the elders have problems, one side there are many solution providers. But is there a central registry for both to access? It's still a question that it's in silos. It's in pocket. A few associations have it. the governments are encouraging elder care players to come and register, but it's fully not gone out there. It'll be nice, Dr. Rana, if you think about an elder, where would he go and shop for senior care services? Either it could be healthcare, anything to do with senior care. A wish list that, you know, a lot of our customers also end up asking is, hey, if I want this, where do I go? You know, so where it'll be nice to have a portal where if it's a centralized registry under the social welfare or the a separate department where an elder can go and access all kinds of senior care services, because there are operators out there, just that there's no listing, a validated listing where it's updated and kept. That will ultimately lead to you know, forming a common pool and a registry where, you know, ultimately where we can where the regulations can come in a very positive manner, because any industry, when regulations come in, there is a fear that, oh, is it going to be punitive? What is going to happen to my business? Because today senior care providers are vary from a very small level to a very high level, but some of them are afraid, sitting back. What will these regulations do? Will they shut down my business? Because I'm not operating, or I don't have the budget to operate at that level of scale with compliance. So these are some of the elements, Dr. Anna, because I've networked very regularly with senior care players, where it's a constant conversation. Where they're kind of afraid while the regulations are coming in, what will happen to them? That is a big question that would burning in our head. And last point I want to also add, while from an operator angle, also it will be nice to have more collaborations with, for example, with urban planning or municipal administration, because ultimately, is the city senior friendly? If you walk around payments or parks or public transportation, is it senior friendly? It's a big question. I don't know if any of our seniors can get into any of the public transportations. Could it? Maybe some of the metros, yes. But it'll be nice if inputs are received from experts, especially with the new smart city projects coming up. At least may not be able to do something which is existent, but at least upcoming cities, where at least in few cities that I know, they are looking at redoing the cities. Smart city projects are coming in. So it'll be nice if we could collaborate with them and give some of the inputs, some very basic inputs that could make life of elderly more independent, as rightly as Raju said. You know, I think from a very dependent mindset, we have to move elders to be a very independent environment where they're able to do their day-to-day activities without much of dependence, so they don't feel they're a burden. They have to be independent, and the environment has to be supportive of it. And that's pretty much from me, Dr. Anna.
No, thanks, Karthik. I think you brought out two very important things. I think if we need money to come in, if we need entrepreneurship to happen, I think the regulatory framework needs to be clear, right? So tomorrow, if I'm doing chemotherapy at home and it suddenly stops, that shouldn't. So I think that's that paradigm. And the second, I think as you build the ecosystem, you know, in planning, do we really look at can a senior use it? And I think that's a mind shift. We've done it for, you know, the disabled, and I think that mind shift that every planning is done for the next 20 years, where you know that people who are even above the age of 80 can access that. I think that was a very important point. I think this has been, you know, these have been great insights, and I think we're just told by the organizers that, you know, we just run out of time. So I think we discussed a lot of things. I think right, starting from Dinesh, how do we bring this together, to Dr. Sunila, what are the skills? Om gave us great insights, right? Do they actually want? And Raju, I think you spoke about the whole holistic piece, and why regulations, again, you know, will be a roadblock if we don't make it happen. And Mayank, I think the whole component of financing and what needs to be done today, modes of financing, and not just looking at insurance, which is more for acute episodic care. And this is a very different model there. And finally, I think, how do you catalyze this growth, which Karthik, you said, you know, let's build those building blocks and move. But I think the whole message I get at the end, if there's a time to act, I think it's now. And let's hope, let's not lose the buzz, as they said. and let's make this report actually something which we can come back in 5 years and say, look what progress has been made since then. I want to thank all my panelists, wonderful insights, and I want to thank the audience for being with us and being such a wonderful audience. Thank you and take care. Back to you, Julia.
Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you, Dr. Mehta and the panelists. That was a stimulating discussion with a number of key takeaways detailing out the areas where interventions are required. With this, we are about to bring this webinar to a closure. This event has brought together industry experts and government representatives, key stakeholders in the process, to lay out their expectations and help chart a way forward for this industry. I would like to now request Mr. Siddharth Bhattacharya, Secretary General at Nat Health, to come on screen for concluding remarks and vote of thanks.
Thank you, Julia. A very warm good evening to everyone. And thank you so much for taking the time. This was an enriching panel discussion. All the speakers have brought together eloquently all the multiple facets required to catalyze this holistic.
By doing something or the other. And couple of
So I would like to summarize some of the key thematic areas that have come up. There's a conversation around financing, which is understanding options for enhanced insurance coverage and depth. Dr. Paul made the point about integration to the PAC strategy, digital health, which involves telehealth used cases for seniors, was one of the very important points of discussions that came together. The entire focus of the discussion was around wellness and well-being, which is establishing a connect with the core issue of the seniors, which is not necessarily always about a sickness or a clinical issue. There is a rapid need for innovation, skilling, capacity building, which touches both lives and livelihood, as well as adoption of standards and self-adoption by industry, opening pathways to regulation in future. There was an entire line of discussion around the need for senior care to be holistic, comprehensive. And this involves having senior-friendly urban planning, modern cities, and an environment that is more friendly to the seniors. The need to have a national aging wellness mission, which establishes common frameworks and brings together information repository, and that creates devolution pathways with robust design and unified public-private partnerships in future. So thanks a lot for many of these conversations are going to be happening beyond this webinar. I would like to take the opportunity to thank many of the players behind the scenes today who are present here, without whom this paper would not have been possible. I'd like to start first by thanking all the seniors of India. I think they are the reasons why this paper, what motivated everyone to prepare this paper together. And I would like to say that it's a small step in the right direction by caring for those who cared for us. And that is the definition, which many of you also mentioned, the spirit of the paper. So thanks a lot to every senior citizen of this country. And many of us who are going to be future citizens also have a large role to play. Investing the time and efforts to improve the senior healthcare system is actually an investment into everybody's future. I would like to thank some key contributors without whom this paper would not have been possible. And some of them are not present in this conversation today. They are Dr. Rakesh Sarwal, Additional Secretary, Niti Aayog, Dr. K. Madan Gopal, Senior Consultant, Niti Aayog. I would like to thank Professor Atul Kotwal, the Executive Director, NHSRC, Dr. Arun Agarwal, Co-Chair FICCI Swasth Bharat Task Force and Medical Advisor, Apollo Hospitals Group, Dr. Gauri Sengupta, DADG Public Health, CHEB, Dr. Vikas Malhotra, Director, Professor, ENT and HNS, MAMC, Mr. Somajit Roy, co-founder and CEO, Imoha Healthcare, and Dr. Ruchika Kuba, Professor IGNO. for giving the technical and academic inputs, which led to framing many of the recommendations in this paper. I would like to thank, of course, the dignitaries who graced the inaugural session today. Dr. Vinod K. Paul, Honorable Member Health, Niti Aayog, for really analyzing succinctly the recommendations, linking that and in towards some to some directions that are already thought, some certain policy decisions and directions which government is already thinking. We certainly would do our best to consolidate everybody's viewpoint and hopefully go back to both him and Mr. Subramaniam, Secretary, Ministry of Social Justice and Empowerment, with some of their thoughts and suggestions out of this discussion. I would like to thank the leadership of all the experts, the eminent speakers who came before this, the last session, as well as the leaders from all the 4 federations, ASLI, FICCI, MTI, and NatHealth, for bringing the entire ecosystem together for this event today. The secretariat team from each of these federations, led by Ms. Sarita from FICCI, Ms. Pani from ASLI, and Anugraha from NatHealth. They are the ones who have really led, done all the logistics and the planning and made this event successful. I would like to thank the communications partners, Avian and Health Business Insights, who pulled together the technical logistics and the communications for this program. With those words, I would like to thank all the 4 federations and their partners, all partner federations, and of course, last but not the most importantly, the viewers and the attendees who have been listening patiently to this event. The recording of this event will be put up on all the social media handles of all the federations. So for those of you who could not attend this, they would have an opportunity to listen to it. I request everybody to forward the link to as many, to those you think would benefit from this session. Till we come back with another session, till soon, thank you so much. Namaste, have a wonderful day ahead.